Welcome back to Let's Talk Wellness Now. I'm your host, Dr. Deb, and we are continuing our discussion this week on peptides. And so if you haven't heard our first conversation about peptides, please go back and look at that episode. We talk all about the manufacturing, the safety, the quality of peptides, and we dove into GLP-1s. And today we're going to dive into peptides for sexual wellness, immune function, growth hormone, and all the amazing fun things we can do with peptides. So, as usual, grab your cup of coffee or tea, settle in, and let's talk wellness now. Now, we're going to take a short pause from our sponsor. I know we've got to do that, you guys. They're who keep us on the air. So, I'm going to pause for just a minute and be right back after this message from our sponsor. Ladies, it's time to reignite your vitality. Primal Queen supplements are clean, powerful formulas made for women like you who want balance, strength, and energy that lasts. Get 25% off at primalqueen.com/Serenity Health. That's primalqueen.com/Serenity Health, because every queen deserves to feel in her prime. All right, everybody, we are back, and are you ready? We are talking all things peptide, and I am opening the show today with sexual wellness. Yes, I'm going there, you guys. I am going there. You know, this has really become a big issue for people of all ages. It's not just us older people, it's younger people too. And there's a whole variety of reasons why we have sexual dysfunction. And when we're talking about sexual dysfunction, we're not just talking about it doesn't work, right? Or I can't reach orgasm. A lot of it is around desire and the thought of it and wanting to connect, wanting to be kinder to one another, wanting to be touching one another. A lot of it revolves around that. And so there are some peptides that can help us, and I'm really excited to be able to talk about those today. So the first one is called PT141. This targets the brain, not the periphery, right? So for many women, I will always tell you, sex starts between here. It is a brain thing for us. It is not necessarily a physical thing. For guys, that's a little different. It's very physical. For women, it's all in our brain. So tip for you men that are listening, you have to prime your woman's brain first if you want her to have sex with you that night. You have to be nice to her. You have to bring her flowers, do the dishes for her, do something kind, bring her a cup of coffee or tea or a glass of wine, take her to dinner. You have to woo her. And I don't care how long you've been married, that has to happen. And tip number 2, don't say anything stupid that day. I'm just being honest. When you guys say things that make us upset, that lingers with us for the rest of the day. And it's a turnoff for us. And for a lot of women, we can't get past that when it comes time to snuggle at night. And sex doesn't always have to be at night either. So you can tell I really love talking about this conversation, but we're going to get into the peptide part of it because this is going to help people. So PT141 is marketed as, I'm going to slaughter this name, Vyleesi, and it represents a fundamentally different approach to sexual dysfunction than the PDE5s inhibitors like sildenafil, Viagra, tadalafil, which is Cialis. And while the PDE5 inhibitors work specifically by enhancing blood flow to the genital tissues, PT141 works centrally in the brain by modulating neural circuits involved in the sexual desire and arousal. Now, PT141 is a cyclic hepatopeptide. It's 7 amino acid peptide arranged in a cyclic structure that acts as a melanocortin receptor agonist. And with particularly the affinity for MC3R and MC4R subtypes, it's actually a metabolite of the melanotan 2, a peptide originally developed for tanning that was also found to enhance sexual desire in early studies. Now, the melanocortin system in the brain is involved in multiple functions, including energy homeostasis, but it also is involved in sexual motivation and arousal behaviors. The FDA approved PT141 in 2019, specifically for the treatment of acquired generalized hypoactive sexual desire, HSDD, in perimenopausal women. So for the first time, we have a medication that was approved by the FDA to use for women for sexual dysfunction. We have had all of these Cialis, Tadalafil, Viagras for men, but we had nothing for women. And so this is amazing that this is available for women and approved by the FDA. It's a big deal. This represents the first and only FDA-approved medication specifically targeting these circuits of sexual desire rather than the peripheral arousal mechanisms. And this indication is quite specific, meaning it was developed at some point, not lifelong. So if you've had sexual dysfunction your entire life, this medication was not approved for you. But if it's something that you developed over time, like when you went through perimenopause or menopause, or some women have this experience happen after childbirth, that's what we're talking about here. Now, it's also not just supposed to be used if you dislike your partner, right? If your relationship is bad and you dislike your partner, this probably isn't going to fix a ton. It might help a little bit, but that's not what it's meant for. So you really have to know what you're using it for and why. And the other thing that I would say is this is something that we don't go to if your hormones are not balanced properly. You have to balance your hormones properly before using something like this because it still may not work. Now, the only caveat to that is if you're a woman that has a risk of breast cancer and can't use hormones, then that's a different story, and we would have that conversation about whether or not this medication would be appropriate for you. Now, the FDA label specifies PT141 as it not being indicated for HSDD in causes where low sexual desire is due to coexisting medical or psychiatric conditions, problems with relationships like we had talked about, side effects to medications or other substance use. This specifically reflects the importance of differential diagnoses. Low sexual desire can have many root causes, and PT141 is only appropriate when those causes have been ruled out. Now, have I used PT141 in people who have sexual dysfunction issues as a result of using antidepressants? Yes, I have. I've used sildenafil in that effect as well. And it does work sometimes, but it doesn't work completely. But you need to know that that is not what the approval is for the FDA. So that is done in something that we call off-label use. So very important to know. Now, in these clinical trials, leading to FDA approval, this was published by Kinsberg and colleagues in Obstetrics and Gynecology in 2019. PT141 demonstrated statistically significant improvements in sexual desire and decreases in distress related to low desire compared to placebo. The effects manifest over 45 minutes to several hours after the injection, and the mechanisms involved modulation of dopamine and melanocortin pathways in the hypothalamus and the brain regions that involved sexual motivation. Now, cardiovascular effects of PT141 require careful attention. This drug causes transient increases in blood pressure, about 3 to 4 points, and transient decreases in heart rate. And because of this, it is contraindicated in patients with uncontrolled hypertension or known cardiovascular disease, and it has been studied in patients who've had recent cardiovascular events. Hasn't been studied in patients who've had recent cardiovascular events. So patients need to have their blood pressures checked before starting therapy. Nausea is extremely common. It is one of the biggest things. I often will tell people to take an anti-nausea medicine if they're going to do this, because the last thing you want to do is inject this medication and think it's going to give you this great time with your partner, and you're so nauseated that you can't even perform. Don't want to kiss, don't want to do anything. It can be pretty profound for some people. It does affect about 40% of the patients in clinical trials, which is why many clinicians require or recommend an anti-nausea medication, like I had just said. Other common adverse effects include flushing, injection site reactions, headache in about 13% of the population, which I have seen worse if people are prone to headaches. And the headaches are pretty intense. So I will also have them pre-medicate if they have that sensitivity with a Tylenol or Advil, Aleve, whatever it is they typically use for their headaches to help prevent that from occurring. Now, some patients also experience a generalized hyperpigmentation of their skin, particularly in areas with chronic friction. and this may not be reversible after discontinuation. So from an integrative perspective, PT-141 represents one tool in addressing female sexual dysfunction, but it should never be the first or only intervention. And low sexual desire in women is complex, multifactorial, involving hormonal imbalances, low testosterone, estrogen deficiency, progesterone imbalances, thyroid dysfunction, adrenal dysfunction, and with elevated or dysregulated cortisol levels, sleep deprivation, relationship issues, unresolved trauma, including sexual trauma, chronic pain, body image concerns, and medication side effects such as SSRIs are notorious for this. So a comprehensive hormone panel, including total and free testosterones, estradiol, progesterone, DHEA, thyroid function, and cortisol assessment, ideally 4-point cortisol salivary, should precede any pharmacological intervention. And additionally, addressing the psychological component and relationship dimensions through appropriate therapy is necessary. I have a lot of patients that say, this is just too much work for sex. I don't want the side effects. I don't want to deal with this. And that's totally fine. But for some people, their sexual dysfunction is actually causing more problems on their relationship, and they want to do something to fix that. And just know that if you're using a peptide like this that comes with some of these side effects and you have to pre-medicate for it, it is not the end of the world, but it may be a possibility that you may need that. So let's dive into body composition and growth hormone access. So tesmorelin is the only FDA-approved GHRH analog. Tesmorelin is marketed as Agrifta and Agrifta SV. It is a synthetic analog of human growth hormone releasing hormone, so GHRH, human growth hormone releasing hormone. These things are such long names. It's confusing and it's difficult to spit out, right? It consists of 44 amino acids. The structure is identical to our own body's growth hormone, GHRH, with the addition of trans 3 hexanol group, which stabilizes the molecule that extends its half-life compared to the native GHRH. The mechanism of tesmorelin is elegant in its preservation of physiological growth hormone, GH, secretion patterns, and rather than administering an exogenous growth hormone directly, tesmorelin binds to the GHRH receptor in the anterior pituitary gland, stimulating the endogenous pulsatile release of GH. So, it's slower in that stimulation and it pulsates instead of a direct rise and fall. This pulsatile pattern more closely mimics natural GH secretion, which occurs in bursts primarily during sleep. The GH then stimulates the liver to produce insulin-like growth factor, IGF-1, which exerts many of the downstream metabolic effects, including lipolytic effects on the adipose tissue. So fat, adipose, and how we break that down. The FDA approved tesmorelin in 2010 for a very specific narrow indication: the reduction of excess abdominal fat in HIV-infected patients with lipodystrophy. This condition, characterized by abnormal fat redistribution with accumulation of visceral body fat and the loss of subcutaneous fat in face and limbs, developed as a complication of an antiviral therapy, particularly with older protease inhibitor regimens. The visceral fat accumulation in patients is not just cosmetic, it's associated with increased cardiovascular risk, insulin resistance, and inflammatory markers. The pivotal trial that led to the FDA approval included work by Stanley and colleagues published in the Annals of Internal Medicine in 2014. It demonstrated that tesmorelin significantly reduced the visceral adipose, measured by CT scan, by approximately 15 to 20%, which is a significant difference, to placebo over a short period of time, only 26 weeks. Now, interestingly, the total body weight typically remained stable or even increased slightly, as the reduction of visceral fat was sometimes offset by increases in lean body mass or subcutaneous fat. This highlights an important point. Tesmorelin is not a weight loss drug in its conventional sense. Its effects are specifically on body composition and fat redistribution. Now, the glucose metabolism effects of tesmorelin do require careful monitoring because GH and IGF-1 can induce insulin resistance. Tesmorelin can increase glucose levels and hemoglobin A1C. And in these clinical trials, glucose tolerance and new onset diabetes occurred in some patients. So this creates a therapeutic paradox. While reducing visceral fat, we should theoretically improve metabolic health. The GH-mediated insulin resistance can worsen the glycemic control, and patients with diabetes require particularly close monitoring. The potential need for adjustment in diabetic medications can occur. So I already know what you guys are thinking. Can I use tesmorelin and GLP-1 at the same time? And the answer is yes, especially in those people that we know have an insulin resistance already or are prone to that. We can use low-dose microdosing GLP-1 along with tesmorelin to help prevent this from occurring or reduce the risk of it occurring. Now, there are some other adverse related problems to growth hormone access, which include fluid retention, which can manifest as ankle swelling, joint pain, muscle pain, paresthesias, carpal tunnel syndrome is common to see. Of course, you can always see injection site reactions reported about 26 to 30% of the time in the trial participants. And this also theoretically has a concern about IGF-1 elevation, potentially promoting malignancy through long-term data is limited. So we have to be cautious about this, but it is a growth hormone, and anything that is a growth hormone can cause cells to grow, and it cannot necessarily differentiate between healthy cells and bad cells. So the drug is contraindicated in patients with active cancer and in patients with the disruption of the HPA axis from conditions like pituitary tumors, pituitary surgery, head irradiation, and traumatic brain injury. Now, off-label use of tesmorelin for general anti-aging or body composition optimization in non-HIV population, it doesn't have FDA approval. There is no FDA studies that promote this, but practitioners do prescribe it for these purposes under an experimental and not supported by FDA approved indications. And from an integrative medical standpoint, optimizing natural growth hormone secretion through lifestyle interventions, high quality sleep is important. GH primarily is excreted during sleep and deep sleep waves. So improving your deep sleep is important. Intermittent fasting can also increase growth hormone by 5-fold, as demonstrated in a Hartman and colleagues study from the Journal of Clinical Endocrinology and Metabolism in 1992. And high intensity interval training, adequate dietary protein, blood sugar control, these all can help naturally increase your growth hormone. So let's dive in now and talk about bone health. Peptide hormones such as I'm gonna really slaughter this name. Teriparatide is a true bone building peptide. It's marketed as Forteo. It's a recumbent form of the first 34 amino acids out of 85 of the human parathyroid hormone, PTH. It represents a unique approach to osteoporosis treatment because it's one of the few truly anabolic bone therapies, meaning it actively binds new bone rather than simply preventing bone loss. The biology of parathyroid is fascinating and seemingly contradictory. Continuously sustained elevations of PTH, as occurs in hyperparathyroidism, is catabolic to bone. So people who have hyperparathyroidism typically have significant bone loss, especially before it's diagnosed. And it causes increased bone reabsorption, loss of bone density, increased fracture risk. And however, intermittent exposure to PTH, as achieved with once daily injections of Forteo, has the opposite effect. This intermittent exposure preferentially stimulates osteoblasts, bone building cells, over osteoclasts, bone reabsorbing cells, and it leads to the net bone formation. So teriparatide binds to the PTH receptors on osteoblasts and renal tubular cells. In bone, it increases the number of activity of osteoblasts, stimulating the differentiation of osteoblast precursor cells, and may reduce osteoblast apoptosis, basically programmed cell death, allowing this bone building cell to work longer. The result is increased bone formation, improved bone architecture, and trabecular connectivity, and ultimately increased bone mineral density. particularly in the hip and the spine, which is so difficult to regain. The FDA approved this medication in 2002 based on pivotal studies by Neer and colleagues published in the New England Journal of Medicine in 2001, which demonstrated significant reductions in vertebral and non-vertebral fractures in postmenopausal women with osteoporosis. Specifically, reduced new vertebral fractures by 65% and non-vertebral fragility fractures by 53% compared to placebo over a median follow-up of 21 months. This is really incredible because we have not seen this kind of change in other medications that we've used for osteoporosis. So current FDA approval indicates this for postmenopausal women with osteoporosis at high risk for fracture, men with primary or hypogonadal osteoporosis at high risk for fracture, and men and women with glucocorticoid-induced osteoporosis at high risk for fracture. The high risk qualifier is important. Terapeptide is reserved for patients with severe osteoporosis, multiple fractures, very low bone density, and those who have failed or are intolerant of other therapies. The most significant concern for this medication is highlighted in a boxed warning with rat toxicology studies where it caused osteosarcoma, which is a bone cancer, in a dose-dependent and treatment duration-dependent manner. The relevance of this finding to humans is debated. Rats have fundamentally different bone biology than humans with continuous bone growth throughout life and different PTH receptors. Now, post-marketing surveillance in humans hasn't shown a clear increase in osteosarcoma risk, but theoretically, concerns persist. And because of this, terapeptide is contraindicated in patients at risk, baseline risk for osteosarcoma, including those with Paget's disease of the bone, unexplained elevations of alkaline phosphatase, prior skeletal radiations, bone metastases, or skeletal malignancies, and pediatric patients or young adults with open hyphae. There's also a lifetime treatment duration of only 2 years, and terapeptide can cause transient hypercalcemia, so an elevated blood calcium. And as PTH normally increases calcium levels by enhancing bone reabsorption, increasing renal calcium reabsorption, and promoting activation of vitamin D, which increases intestinal calcium absorption. Some patients experience orthostatic hypotension within 4 hours of injecting, requiring caution in at-risk populations for blood pressure. Common side effects include muscle pain, joint pain, pain in the limbs, nausea, headache, and dizziness. So from an integrative bone health perspective, terapeptide should be part of a comprehensive strategy. Adequate calcium intake, 500 to 1,000 milligrams of calcium a day from food and supplements combined, and vitamin D. Getting vitamin D levels of at least 50 to 80 are essential for the drug to work optimally. But beyond this, bone health requires vitamin K2, which directs calcium into the bones rather than soft tissues, magnesium as a cofactor in bone metabolism, trace minerals like boron, copper, silica, and of course, adequate protein intake, which many of us, especially as women, don't do, 0.8 to 1 grams of protein per kilogram of body weight. Weight-bearing exercise, of course. These all provide mechanical signals that complement the biochemical signals of terapeptide. Sequential therapy is also critical. The bone mass gains from teriparatide can be lost if patients don't transition to an anti-resorbative agent, a bisphosphonate, after completing this therapy. And the anabolic effects to build bone, but maintaining the new bone requires preventing excess reabsorption. So positive things about this, but there are definitely some concerns as well. So the next one we're going to talk about is Luprolide. It is marketed under the multiple brand names of Lupron, Depo, Eligard, and it's a synthetic non-apeptide analog of naturally occurring gonadotropin-releasing hormone, GnRH, also called luteinizing hormone releasing hormone, LHRH. It's a fascinating example of how manipulating natural hormonal feedback systems can create therapeutic effects. So GnRH is normally secreted in a pulsatile fashion by the hypothalamus and travels to the anterior pituitary, where it binds to GnRH receptors and stimulates the release of luteinizing hormone, LH, and follicle stimulating hormone, FSH. These gonadotrophins signal the ovaries or the testes to produce sex hormones, estrogen, progesterone in women, testosterone in men. Leuprolide, Lupron, as a GnRH agonist, initially mimics the action of natural GnRH, causing an acute flare response with increased LH-FSH secretion, which temporarily increases sex hormone production. However, the continuous administration, which is in the depot formulations, the GnRH receptors in the pituitary become desensitized and downregulated. And after about 2 to 4 weeks of continuous exposure, LH and FSH secretion is profoundly suppressed, leading to what's termed as chemical castration. Testosterone levels in men drop to castrated levels less than 50, and estrogen production is markedly suppressed in women. This biphasic response creates both therapeutic applications and management challenges in prostate cancer, where tumor growth is typically androgen dependent, and the ultimate goal is testosterone suppression. However, the initial testosterone surge during the flare phase can temporarily worsen symptoms, potentially causing increased bone pain, urinary obstruction, or even spinal cord compression in patients with metastatic disease. This is why leuprolide is often started with an anti-androgen like biclotamide for the first 2 to 4 weeks to block the effects of the testosterone surge. The FDA has approved leuprolide for multiple indications across formulations in oncology. It's used for palliative treatment of advanced prostate cancers. In gynecology, various formulations are approved for endometriosis, for pain management and lesion reduction, and for fibroids. Typically for preoperative hematological improvement in anemic patients. In pediatrics, it's used for central precocious puberty, basically to halt the premature sexual development of these young people. Now, there are adverse effect profile that reflects profound hormonal suppression. In men treated for prostate cancer, hot flashes affect about 59% of the patients. Other common effects include general pain, swelling, bone pain. Long-term use of these medications leads to metabolic changes. It increases fat mass, it decreases lean mass, it worsens insulin sensitivity, disrupts the cholesterol lipid panels, increases diabetic risk, has some concerns over cardiovascular disease. And the meta-analysis have shown increased risks of heart infarction, myocardial infarction, sudden cardiac death, and stroke in populations receiving long-term androgen deprivation therapy. The bone effects are particularly dramatic. Without sex hormones, bone density decreases significantly, typically 3 to 4% per year during the first 2 to 3 years of therapy. And this bone loss may not fully be reversible after the therapy discontinues. The American Society of Clinical Oncology recommends bone density monitoring and consideration of bisphosphonates in men receiving long-term androgen deprivation. In women treated for endometriosis or fibroids, the estrogen suppression creates a hypoestrogenetic state similar to menopause. Hot flashes affect 90% of patients, with other common effects including headaches, emotional irritability, decreased sex drive, vaginal dryness, bone density loss. And because of these bone concerns and treatment duration with endometriosis typically limited to 6 months, though some formulations allow for longer use with add-back hormonal therapy to partially mitigate these side effects. The mood and cognitive effects can be significant. I've seen it over the years. The depression, the memory impairment, difficulty focusing and concentrating. It can be very, very traumatic, and the quality of life that happens for these women and men can be unbearing for many of them. From an integrative perspective, patients receiving this medication need comprehensive support care. Bone health interventions using calcium, vitamin D, vitamin K2, weight-bearing exercise, cardiovascular risk management becomes critical, including blood pressure monitoring, lipid management, diabetes screening. For hot flashes management, some patients respond to black cohosh, sage, or vitamin E. Though evidence is mixed and individual response varies, omega-3s may help with the mood and the inflammation. Resistance training becomes specifically important to preserve lean muscle mass in the face of hormonal suppression. Now, there's something called calcitonin salamin, which is marketed as miacalcin. It is a nasal spray. It is now discontinued, and Fortical is the new synthetic polypeptide hormone of 32 amino acids identical to calcitonin of salmon origin. It represents an interesting case study in how initial promise gives way to safety concerns that regulate a therapy to historical footnote status. Calcitonin is naturally occurring hormone in humans. It's secreted by the parafollicular C cells in the thyroid gland. Its primary physiological role is to lower blood calcium levels by directly inhibiting osteoclast activity, reducing bone reabsorption, increasing renal calcium secretion or excretion, and possibly reducing the intestinal calcium absorption. So salmon calcitonin is used therapeutically because it's more potent and longer acting than human calcitonin. The FDA initially approved calcitonin salmon for several indications: postmenopausal osteoporosis in women, more than 5 years postmenopausal when alternative treatments are not sustainable, Paget's disease for bone, and hypercalcemia as emergency treatments. The nasal spray formulation is particularly popular for osteoporosis because it offered a non-injectable alternative to bisphosphonates. However, in 2012, the European Medicines Agency, EMA, conducted a comprehensive safety review after a pooled analysis of 21 clinical trials involving over 10,000 patients, showed a statistically significant increase in malignancy risk in patients treated with calcitonin salamin compared to placebo. The overall malignancy rate was 4.1% in calcitonin treated patients versus 2.9% in placebo patients. The types of cancer varied, with no single cancer type predominating, making it difficult to establish a clear mechanistic link. However, the signal was concerning enough that the EMA restricted the use of calcitonin-containing medicines. In the United States, the FDA issued communications about malignancy signal and conducted its own review. While they didn't fully withdraw the drug, the consensus shifted dramatically. The nasal spray formulation's miacalcin was voluntarily discontinued by the manufacturer, and current clinical practice guidelines now consider calcitonin salamin as a second line or lower option for osteoporosis, while behind bisphosphonates, denosumab, terapeptide. The analgesic effect of calcitonin in bone pain, particularly in acute vertebral compression fractions from osteoporosis or Paget's disease, may still provide a role for short-term use in these selected patients. The mechanism of this pain relief is unclear, but may involve effects of endorphin systems and or direct actions on pathways. The history serves as an important reminder in peptide medicine. Initial approval and early clinical use does not guarantee long-term safety effects. Post-marketing surveillance and pooled analysis of the clinical trial data can reveal adverse effects that weren't apparent in initial studies. It also underscores why newer agents with better safety profiles have largely replaced calcitonin in clinical practice. So this is really an important thing. Not one thing stays the same forever. We have to change as we identify new and better products, as we identify problems and concerns. I will always tell my patients, if you are uncertain of taking a new drug, which we all should be, wait 5 years. Within 5 years, we are going to find the problems that they didn't find in the clinical studies. Remember, a lot of these clinical studies are small groups, short periods of time. It's expensive to do these trials. So if you wait for 5 years, in the first 2 to 3 years, you will see the problems start to emerge. And what are you going to look for? You're going to look for the news commercials from lawyers suing a drug. And they will tell you what the problem is. And then you can decide, is this something that I want to use or not? Don't jump on bandwagon and be the first one to do this, especially if you're sensitive. Give it time so you can see exactly what's going on. So I'm going to end our show on this, and we're going to pick up on part 3 of peptide therapy in our next segment, where we're going to talk about the investigational peptides and some exciting things that are happening with that. So I want to thank you for joining me today on Let's Talk Wellness Now. It's always a pleasure having a conversation with you guys, and I hope this brings value to you with what we're talking about. If you have ideas for topics that you want me to discuss, please message us. You can share your comments on Facebook. You can email us. You can get a hold of us however you would like to share that. I do look at the comments below in the episodes as well, so you can place your comments there. And once again, one of the best things you can do for me is like, subscribe, and share so that we can spread the messages of what we're doing. I do this at no cost. I don't make any money out of this. I do this as an educational purpose for everybody else. I love doing it, but it really helps us on the algorithms if you would be just willing to like, subscribe, and share. So thank you for spending your time with me. I know time is important. I greatly appreciate it. And I hope you guys have a fantastic rest of your day.